try to make some sense of this chapter. You know, again, that end of that chapter just seems like it's kind of all over the place, just throwing lots of terminology and so forth. So I do want to make sure we hit some of the terminology that they use, but understand that some of that terminology is specific to that book, and you read other textbooks, and there's some really challenges in defining, you know, motor disorders, and especially when we talk about tone and spasticity, velocity-dependent hypertonia, myoplastic hyperstiffness, it gets really kind of murky as far as, so I'll try to say this is what you should know for the test, you know, focus on these slides for some of those specific definitions and things, and what I've interpreted them as, and kind of looking at the bigger picture. So we mentioned that if you have a problem with your nervous system, the most common symptom that you will have with a disorder of the nervous system is some type of motor problem, okay? Those motor problems will manifest themselves in any one or more of these combination of areas, okay? So some problem with your muscle strength, the ability to forcefully contract a muscle, and also possibly bulk of your muscles, because often you'll have some atrophy if you have weakness for too long. The ability to contract your muscle, different from strength, but does it over-contract your muscles? Do you have too much co-contraction between agonist and antagonist? Not enough contraction, those kind of things. Is there excessive contraction or abnormal involuntary motions, okay, so that there's too much movement and it's involuntary in nature, and that can kind of sometimes fit under this muscle contraction, involuntary muscle contractions. It's normal to have some involuntary muscle contractions, but some obviously are not. Muscle tone, just regulation of resting tone of your muscles. We all have a certain amount of tone that's normal. It's normal at rest and also during activity, so changes in tone, up or down, okay? And then reflexes, so whether that be tendon reflexes, whether that be cutaneous reflexes when you're, you know, touching a spot of skin or something like that, those can be altered and abnormal. Movement efficiency and speed, so not just strength, power, contraction, but the efficiency with which you move, the speed with which you can move, coordination kind of falls under that, you know. Those are motor problems. And then lastly, postural control, okay? So what's your postural control? One of our research subjects. The ability to stand up and maintain, or sit and maintain appropriate postural control without falling over, without losing your balance, those kind of things. Those are all things that can be affected by any problem with the motor system can potentially influence one or more of these. So let's kind of focus on these a little more specifically and go through those. So starting with the first one is changes in muscle strength and bulk, okay? So there's some terms that are used commonly to describe weakness, okay, or atrophy. And so if you use the term paralysis, that is a complete loss of voluntary muscle contraction. If you say that a muscle is paralyzed or has paralysis, that typically indicates that it doesn't contract. It's lost innervation, it's paralyzed, whether that could be from an upper motor neuron or a lower motor neuron disorder, okay? So that could be a peripheral problem or a central nervous system problem. You most often hear it with upper or central nervous system, but you know, somebody with polio, you know, that has an anterior horn cell that's damaged, polio affects just the lower motor neuron, the anterior horn cell, and if they've got a, you know, a limb that is what we call flail limb or a flaccid limb that just doesn't, and that's a paralyzed, or they have paralysis in that limb, okay? Paresis or plegia, okay, is a partial loss of function, okay? And you'll hear terms like hemiplegia or hemiparesis, okay? So those terms are somewhat used interchangeably. You could lose paraparesis or paraplegia or tetraparesis or tetraplegia, okay? That's a partial loss. So hemiplegia is half your body. And typically with these, there's still some movement even with those. Even though they have paresis on half their body, they may be able to elicit some voluntary movement, but it's stereotypical in nature. It may not be under complete voluntary control, but it's not fully gone, you know. Paraplegia, you know, that's a spinal cord injury that below a certain level they have two limbs, their legs are impacted with paraplegia. Tetraplegia also called quadriplegia, but actually the more formal or better term they currently use is tetraplegia. That would be paresis from all four limbs, okay? But they can still have some movement oftentimes. So even if you don't have to be a tetraplegic or have quadriplegia, you could still move your limbs. But if as long as there's any weakness in your four limbs, that's considered tetraplegia. You have some type of weakness in all four limbs as tetraplegia. And that can range from no movement to almost looking like you wouldn't even notice that they have tetraplegia. Somebody with an incomplete spinal cord injury in the cervical spine, you may be able to notice some small changes in strength and some maybe increased reflexes in their legs and arms, but they may be walking down the street and they're tetraplegic. And you wouldn't even necessarily maybe be able to identify that. So that's partial loss, is this term paresis or plegia. And then oftentimes with paresis or paralysis, you have atrophy. Over time, muscles atrophy. They get smaller, okay? Sometimes the atrophy is from disuse, and sometimes it's from the actual neurologic problem. So if you have a lesion in a nerve or in a pathway that's going to a specific limb or muscle, the neurons that are supposed to supply that muscle aren't working properly, you're going to get some loss and atrophy due purely to the neuronal loss, okay? If it's a lower motor neuron problem, that last final nerve, you're getting nothing going to that muscle, not even from the spinal cord. You're getting, that nerve is dead, that final nerve that innervates that muscle. Because you lose that trophic input. Normally when you have your nerve cells, your lower motor neurons in the spinal cord, they're turned on a little bit. They maintain that muscle tone because they fire, kind of just, you know, they have a systematic firing rate. They maintain some muscle tone and to maintain your muscle's health. If you lose that, the muscle goes silent, and then that causes really rapid decline and really profound atrophy. Somebody has damage more in the upper motor neurons like brainstem, spinal cord, they still have those reflexes in the spinal cord. The anterior horn cell and the peripheral nerve are still okay. So there's still some communication between the spinal cord and the muscle that maintains its somewhat health. But it still atrophies over time. And then if a person now is no longer able to get up and walk around or do activity, there's some disuse atrophy that is superimposed on the atrophy just due to the neuronal problem. Does that make sense? So just because they're not using the muscle, they can get some atrophy. So how do we assess muscle strength and bulk? You guys have already learned the most common way is manual muscle testing, not the most accurate or sensitive way to measure it, but hey, it works in a pinch. So MMT, handheld dynamometry, you've learned how to use those dynamometers that help quantify that better. Still not perfect. And then like there's even a computerized dynamometer where they're sitting on like a big Biodex machine and they can assess those joints a little more accurately. That's mainly for strength, okay? Then for bulk, tape measures, you know. Wrapping tape measures, looking at girth, okay, is how you can compare side to side. And then or a volumetric or volumeter where you stick the arm or limb down in water and see how much water it displaces, and you can compare that side to side. That's a way to look at a whole limb. We typically don't do that for muscle bulk. We typically do that for somebody who's got lymphedema or swelling, and we're trying to see how much swelling they have. But so tape measure, I use that quite a bit. It's amazing how profound, you're like, wow, look, that leg looks a little different than the other. Then you take a measurement in certain areas and you can tell and see, wow, that's like 1.5 inches, you know, narrower, you know, than your other limb, you know. So that's a really profound loss of bulk. And then the next area we want to talk about in common signs is this muscle contractions, particularly involuntary muscle contractions. So when somebody has muscle contractions that they're not in control of, that can be a sign of a motor problem, okay? So this is some of the terminology associated with these involuntary type motor contractions or muscle contractions. First one is muscle spasms and cramps. These are sudden involuntary contractions of the muscle, okay? You know, you've all had a cramp and you wish you were in control of it because then you could relax it and let it go, but it's happening and you're in severe, severe pain. But it doesn't necessarily mean that you have an abnormal nervous system, because we've all had cramps, right? So it's an abnormal neuromuscular phenomena that's can happen to a normal person, but it's not typically, you don't have them all the time, so it is somewhat of a more random event. Now, people with nervous system problems tend to have more spasms and cramps than somebody with a normal nervous system, okay? You know, we tend to get them when we're, and there's no good evidence that says like electrolyte imbalance or magnesium and all that kind of stuff, or apple cider vinegar is going to help, although there's some, you know, there is some evidence that there's like some of the, what's it, apple cider vinegar or pickle juice or that kind of stuff. It's probably some type of, it's not like an electrolyte type of imbalance, it's probably some neuromuscular phenomena where there's fatigue potentially involved, and then there's abnormal signals going to those motor fibers, and you contract them abnormally, and then they stay contracted and don't know how to turn themselves off. So it's more of a neuromuscular phenomena than a physiologic phenomena, and they don't know exactly all the reasons. So there's some that are more peripheral in nature, then some people might have more central mediated problems where some of their brainstem pathways may be abnormal, that are abnormally activating these. So there's variation in what they think causes these. Nobody's got the perfect cure yet. So fasciculations is another type of involuntary muscle contraction. These are quick twitches of muscle fibers of a single motor unit. So a single motor unit is one anterior horn cell in all the motor fibers it's innervating. Okay, so one anterior horn cell going out to all the motor fibers innervated. So it's one anterior horn cell misbehaving and kind of going, you know, bleep, bleep, and just kind of sending random signals. And again, we don't often know why. It can be mediated by too much caffeine, not enough sleep, too much stress, or some people have fasciculations, like a genetic predisposition is to having these little fasciculations going on. You know, I told you about my left eye. It's getting a little better lately, but my left eye was, upper eyelid was just fasciculating a lot, you know, and who knows, age, whatever, you know, stress, sleep, those kind of things can influence that. However, we do find that some people who have nervous system disorders can have more fasciculations, and they can be abnormal. However, just because you have fasciculations doesn't mean it's an abnormal thing. They are common in people, okay? But people that have certain nervous system disorders, like ALS, can have more fasciculations. It can be a symptom or sign. So, do you have
Were you saying that, like, sometimes if you have, like, a full bladder or something like that, you might get these?
that would be more for the autonomic dysreflexia.
Okay.
Yeah, that would be totally separate from fasciculations. So, but so I think there's a video here showing this is a gentleman that has ALS, and you can see in his chest area those fasciculations happening. You can see the profound atrophy he's got, but you can also see the fasciculations. So he's got multiple motor units firing there, not just a single one, but those are all single motor units that are firing, but at different locations up and down his spinal cord that are causing that at different levels. Okay. Typically with a fasciculation, you cord. Wrong one. Typically with a fasciculation, they're only visible on the surface. There's no joint movement. You might see skin move, like my eyelid moves or something like that, but you're not like, fasciculations don't cause an actual joint to move. Okay, they're not big enough to cause joint movement. And they, like I say, for most people, they're normal, unless you've got another problem. Fibrillations are different from fasciculations. They are a brief contraction of a single motor fiber. So not a motor unit. A motor unit is the whole anterior horn cell and all the motor fibers it innervates. This is a single motor fiber kind of misbehaving and just going, you know, just spontaneously firing, okay? The motor fiber is spontaneously firing, okay? Most of the time, this is not visible, okay? It's because it's such a small, just one motor fiber is firing. The only way you pick it up is with the EMG, you know, an oscilloscope. And so either needle EMG or surface EMG, and you put the needle into the muscle, and then you're looking at a little readout, and you see blip, 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 and it's just these little random firings of motor fibers, not motor units, but individual motor fibers that are just spontaneously firing, okay? if you have fibrillations, those are always abnormal. Fasciculations can be normal, but fibrillations are always abnormal. They can be caused by both upper or lower motor neuron problems. So damage to the pathways in the brain, brainstem and spinal cord, or to the peripheral nerve going to the muscle. You damage anywhere along there, you can have fibrillations. They tend to be worse with lower motor neuron problems than upper motor neuron problems. It's really what happens is when you de-innervate a muscle, you take away that, especially that final common pathway, that lower motor neuron that maintains some connection with the muscle and gives it some, that trophic input we call it, some signals and keeps it kind of healthy and saying I'm still connected to the nervous system. When you remove it from the nervous system, it doesn't know what to do. And it kind of like starts to just have these little random firings by itself of those little motor fibers. So it tends to be worse with lower motor neuron than upper motor neuron, but it can occur with upper motor neuron problems, and they're always abnormal fibrillations. And you really can only detect it with some type of an EMG unit. Then we have what's called hyperkinetic disorders that all involve involuntary types of muscle contractions, okay? These are generally diseases that are associated with basal ganglia disorders, and we're going to talk about that later on in this lecture as a class of motor disorders as basal ganglia disorders, okay? And then we'll obviously talk about on Tuesday what the basal ganglia does and why when you have problems with the basal ganglia it can lead to too much movement or too little movement, depending on where in the pathway or the connections in the basal ganglia that you damage, okay? In this case, we're talking about ones that lead to too much movement, okay? So this is damage to the basal ganglia that allows too much excessive movement that's not under your control, okay? So we talk about things like tremor, athetosis, chorea, and bulismus. Those are the most common terms you see associated with basal ganglia dysfunction that involves too much movement, okay? Parkinson's disease that we'll talk about, it's a basal ganglia disorder that has actually a little bit of both. It has too much movement in the tremor that it has, but then it has bradykinesia and too little movement for other things that are important, like walking, you know, and moving in and out of a chair and moving your limbs voluntarily. It's too little movement, but at rest they have too much movement sometimes. They have tremor. But there's other disorders, athetosis, chorea, and bulismus, that are very interesting disorders that are more rare than Parkinson's, that involve problems with circuitry in the basal ganglia that cause too much movement. So I think it's easiest to see some of this stuff than to try to, and there's some overlap. I'll show you a table here that shows you there's some overlap in some of the characteristics of how you describe these movements. So tremor. This is a very unique presentation.
Tremor consists of rapid involuntary movements of agonist and antagonist. In the following video, you are
This is
about
somebody
to
with
see
Parkinson's disease.
Parkinson's disease.
That's a lot more rapid than I typically see. It's usually a little more, 14 cycles per second or so. This is a really, almost looks like he's faking it to me. And because you'll see,
Initiation of purposeful movements. Here we see the tremors of both hands ameliorated during purposeful movement and recurrence of tremor after the hand rests on the knee. This is the classic rest tremor of Parkinson's disease.
that music really adds to it, doesn't it? Now watch this. As soon as he touches his hands down to a resting position, they go back to tremor. So what's unique about tremor, at least in the case of Parkinson's disease, is it's only at rest. The tremor only happens at rest, but as soon as you start to move, the tremor goes away, okay? And when you're asleep, the tremor goes away. It's only when you're at rest and awake, not when you're asleep, but then when you move the limb, it goes away. And as soon as you stop in a new position, even if you were to stop up there, he didn't stop. He just stopped briefly up there. But if you were to hold it there for a while, you probably start to see it happen again. But it does tend to happen more when you're actually physically resting the muscles, because up here you're getting some co-contraction of the shoulders, and that helps kind of stabilize the joints. But as soon as you rest it, and it can be the leg, you'll see tremor in the leg. You'll see tremor in the lip or face. You can have tremor or a combination of those tremors. So that's tremor. Athetosis. Let's look at athetosis. Athetosis tends to be more in the upper extremity. And it's kind of like this snake-like writhing motion of the upper extremity. You can see that there's a lot of rotatory component to it. It's very rotatory, and some people even say like it's like a riding kind of motion that it looks like in some cases. So you can see it again there. It tends to be more distal than proximal, although the proximal is still involved because there's all this rotary kind of stuff. It's more obvious distally. Okay. Versus chorea. Chorea can involve upper and lower body. Okay. Great.
It's tiny, so you can stick it on.
During the Middle Ages, and later to describe the abnormal gait and stance of patients with Sydenham's chorea. We now use the term chorea, however, to define a class of abnormal involuntary movements. Choreic or choreatic movements consist of individual, brief, purposeless, non-repetitive jerks of individual muscles. These tend to be rhythmic and non-patterned, but they appear in series or groups, which result in rather complex movements. The movements are made more complex by the patient's attempts to mask them by purposeful movements. Here we have a patient with fairly severe choreatic movements involving various parts of her entire body.
So chorea involves the entire body versus more athetosis is more distal limb. These muscle contractions are brief in nature and they're non-purposeful, but the problem is oftentimes they try to mask them when they're coming on, and so they look semi-purposeful because they're trying to like do something to try to mask the movement.
Choreatic movements are due to Huntington's chorea. The individual movements, however, look the same no matter what the etiology of the choreatic disease.
Choreatic diseases that cause chorea, in this case she had Huntington's chorea, which is a genetic type of dysfunction or degeneration of the caudate and putamen, but any damage to the caudate and putamen in the basal ganglia can lead to choreic movements. Okay, doesn't have to be just from Huntington's to chorea, but it can be some other disorders and damaging to that. And then here's bulismus. These are more rapid individual flailings of the limbs, okay?
William, can you scoot back up on the bed? Can you scoot back up on the bed? Reposition yourself.
This is probably going to be what your first patient's going to be like when you first walk in. You see your first neuro patient, and you're going to be like, here you go. Your CI is going to say, good luck, go for it.
Yep.
So that's bulismus, this rapid flailing of limbs, and it's actually, bulismus is kind of like throwing a ball. That's why it's bulismus. That's when the person who came up with this, that's like they would make these ballistic motions like they're throwing a ball. That's kind of how I remember it, and that's actually why the terminology was used. So this is a little chart that kind of helps to kind of show what's in common between these movement disorders. So I've got chorea, bulismus, and athetosis across the top. Tells you about the speed with which these contractions happen. Chorea and bulismus tend to be rapid in nature, okay? While athetosis tends to be more that slow writhing motion, okay? They're all involuntary types of movements. They're all non-stereotypical in nature, okay? So they all are kind of random in nature the way they look. It's not this repetitive stereotypical pattern. Now tremor is repetitive. Tremor is more of a stereotypical pattern. chorea can look they're all considered non-purposeful, but chorea can look semi-purposeful because they'll often try to mask the movements with their own purposeful movements, incorporate those into it. So then chorea is more dance-like in nature, especially when they get up and walk. If you watch them walk, they have this very characteristic, looks like they're dancing as they're walking, so that's dance-like looking. Where the bullismus is more that violent flinging, and it can be it even in one limb, like a leg or an arm, or it can be the whole body, like you saw that before. Where athetosis tends to be more upper, it has a propensity to affect the upper body and look almost like this writing disorder, like they're almost trying to write with their limb, but they can't quite figure it out. From a standpoint of distal or proximal, chorea tends to affect more distal and cause more distal issues, where bullismus is more proximal, like these big muscle movements of entire joints, and because there's proximal movement going on, where chorea might even be more distal type movements. Okay, and then the athetosis tends to again just affect more the upper limb. So hopefully that makes things a little clearer in how to discern between those. Okay, oh yeah. I don't think typically it's not painful. There's another type of movement disorder called dystonia, where you have a sustained contraction, and that's kind of falls under the spasms and cramps. There's a very severe form called dystonia, which is also could be a basal ganglia disorder, where they get this posturing where the muscle just tightens and they can't relax, and it's like having a massive spasm, and that can be very painful. But these are usually fast enough, unless they have a bad knee or bad back or some other joint problem that's causing some irritation and pain with. So the bullismus is very characteristic of a lesion in the very specific part of the basal ganglia circuitry, the subthalamic nucleus or subthalamus. So if you've got subthalamic damage, the nice part about bullismus is most of the time it gets better on its own pretty quickly. Even if you have got a stroke in the subthalamus, your body adapts to that, and you just don't have that bullismus. But there can be other causes. You know, it could be drug overdose that causes, you know, that they get lack of blood supply to those subthalamic structures or something like that, you know, or a stroke or a tumor in the area that's of the subthalamic nucleus. Let's talk about muscle tone now. We're still on all these different characteristics of motor disorders. So under the big heading of muscle tone, this is a big one, okay? You can basically have it being too low or too high. You know, you got your normal resting muscle tone, which even within normal resting tone, there's some normal variability. You know, some of us are floppy, you know, and just kind of, you can just tell people that, you know, I'm just jealous of these people that can just relax no matter where they at. They just kind of, you know, you see them sitting and they sit in these crazy postures, and they're seem like they're more flexible, and they just kind of like. Then there's the people that are just real. They have a higher tonal set that tend to have better, you know, posture. They just look like they're a little more stressed or a little bit, you know, constipated. I don't know, but But there's a normal range or spectrum. You just have to handle enough people's limbs to know that's normal lower tone person. This is a normal higher tone person. And then when you get into like, ooh, this is really hypotonic. This is below what I consider normal lower end of tone for a normal person. And this is higher than the higher end of tone for a normal person. And those are the people, you know, by testing reflexes, you can kind of evaluate that. If somebody says, oh, I've never been able to get a reflex out of me, well, it means you just have more of a lower tonal set in your system, probably. Doesn't mean you're abnormal or that you can't still, you know, be a success in life, and vice versa. If you've got hyperactive reflexes, same thing. So hypotonia is so underlying abnormally low resistance to passive stretch. Okay, but there's still some. You know, if it's just hypertonic, and they have hypertonia, there's still some resistance to movement that you can just tell that their muscles are somewhat still turned on. And then there's what's called flaccidity. Flaccidity means that they have no tone. And you can just tell when that limb is totally dead weight. Because most people, when you pick up somebody's leg or you pick up their arm, you almost have to tell them, relax, let me have it, let me have it. And then even when they say, let me have it, they almost sometimes still want to almost help you with it sometimes, and you feel a little resistance to movement. But when they're flaccid, you know, you're like, oh my God, you're just trying to get their leg up and lift it and then move it, and they're just not helping at all. There's like no stability in their hip or knee, and you just feel like you're trying to, keep a hold of that limb, and it's just very dependent. That's flaccidity. That's true flaccidity or no tone, okay? You typically only see flaccidity, true flaccidity, in two cases. Right after a major neuronal injury to cerebrum, brainstem, or spinal cord. So within the first few hours, days, sometimes up to first 2 weeks, usually doesn't last that long, so you can have neuronal shock, we call it, where the nervous system goes kind of into shock. Especially if you injure a big region, so if you got a big brain injury like both hemispheres, or you got swelling in your brain, or a spinal cord injury that involves the whole spinal cord, everything below that was normally getting some influence from higher centers down to those motor neuron pools in the spinal cord all of a sudden goes silent, because it's like all of a sudden it doesn't know what to do. There's like no more normal input coming down from above, and for a temporary period of time it just shuts off and it says, I'm not even going to send signals out to my muscles. I'm going to shut down and figure out what's going on here. Then over a period of time, those reflexes start to happen again and kick back in. Then they actually get hyperactive, okay? But there's a temporary window in time with an upper motor neuron problem, cerebrum, brainstem, spinal cord. If you've got a big lesion that involves, a lot of those pathways or descending pathways that are going down to influence those lower motor neurons, if they get knocked out, they can be flaccid, okay? For a couple days, a couple weeks, but then eventually tone starts to return, okay? Those reflexes at the spinal cord level start to turn back on, but they're usually a little overactive once they finally get up and going again, okay? That's the first reason you can have flaccidity. The other one is because of a profound lower motor neuron problem. So when you actually cut a nerve, damage a nerve, or have peripheral neuropathy, if you've got peripheral neuropathy so bad that no signals are going to your lower leg and foot muscles, then your lower leg and foot can be truly flaccid. It's just paralyzed and flaccid with no tone in those muscles. Lower motor, or polio, or a big peripheral nerve lesion that you cut a peripheral nerve going to all those muscles downstream can be flaccid because they're getting no signal at all. Hypertonia is abnormal high resistance to passive stretch, okay? So you take it and you move the limb and you're feeling, ooh, this is harder than it should be. Even when the patient's trying to relax, it's like, I'm having to work here, I'm feeling a little catch, and I'm having to push, in a certain direction. It can be in one direction, it can be in both directions, depending on the type of or nature of the hypertonia. So that's like abnormally high resistance to passive stretch. If it is velocity dependent, so if you're taking somebody's limb, we'll do this today in our quick lab, you'll move the limb. If you move it slowly, we just call that increased muscle tone, if you feel resistance when you're just doing it slowly. But if you notice that the faster you move it, the more resistance you get. So if I go a little faster, I'm feeling even more resistance. I go a little faster, it's even more resistance. That's spasticity, okay? Spasticity is velocity-dependent hypertonia, okay? So increased muscle tone is what I consider, or hypertonia, is the resting state when you're moving the limb slowly, is what you're trying to assess, the resting state of the muscle. Spasticity, or spastic velocity-dependent hypertonia, is called spasticity, is where the faster you movement, the more resistance you encounter, because you're eliciting that stretch reflex, right, on top of it. When you're doing the slow movement, you're not trying to elicit any kind of a stretch reflex in those muscles. It goes back to the spinal cord. It increases the activity in the agonist muscle. So spasticity is velocity-dependent hypertonia. If a person has what's called rigidity, so spasticity tends to be where it's only in one direction. Like when I flex the hip, I feel that spasticity kick in, it resists, but when I extend it, I don't feel that. Even if I'm going fast, spasticity tends to be in one direction. Rigidity is both directions, so the limb is tight in both directions. So no matter how I move it, and often rigidity is not velocity. It's not velocity dependent. Sometimes it can be, but it's typically velocity independent. So this is where you take a limb, and no matter what speed you move it, fast or slow, it's the same. And it's bad in both directions. You feel the same amount of resistance in deflection as the same amount in extension, maybe the same in rotation. So you just feel like the limb is rigid. Okay, that's more common with Parkinson's disease because they have co-contraction of muscles on each side of the joint. They get stiff and rigid, where stroke and other disorders, brain injuries, tend to cause certain muscle groups like extensors in the leg to be more tight and spastic than the flexors. So when I try to flex the lower extremity, I feel more resistance because I'm trying to stretch those extensor muscles than when I extend the limb. Okay. Damage almost anywhere in the motor system can alter muscle tone. I already talked about upper motor neuron lesions in that initial spinal cord shock or CNS shock. There's a couple forms of rigidity that, when we'll show you a picture here, that your book refers to that are not associated with Parkinson's disease, but they're associated with damage to significant regions of either your cerebrum or brainstem. And they're kind of called decerebrate rigidity or decorticate rigidity. Okay? So decerebrate rigidity is where you have both upper extremity and lower extremity extension. Okay? And the way I kind of remember that they're both upper and lower extremity extension is you've got all these E's in here. E is extension, extension, extension to me. So upper limb is extended, lower limbs are extended, and their back is even extended, their head is sometimes extended. I've had people with such severe decerebrate rigidity that their only thing touching is their heels and their occiput. And they get sores on their occiput and their heels because their back is so arched so you have to pad them well and make sure they're distributing the load. Those are bad. That's bad. You know, if you have decerebrate or decorticate rigidity, those are bad signs for your recovery. Okay. And then decorticate rigidity is a severe lesion. So this is a severe lesion in the midbrain, causes decerebrate rigidity. Decorticate rigidity is severe lesions above the midbrain. So in the cortical, in the cerebral hemispheres, okay, somewhere. Okay. Decerebrate is down in the brainstem. So decerebrate is typically worse. If you have a lesion down in the brainstem in the lower, that's typically even worse. That means your brainstem is also involved. And oftentimes, with somebody with decerebrate rigidity, they typically have both the cortex and the midbrain involved, and that's where you see that. So that usually means like, that's not a good sign when you've got lack of brainstem function plus cortical function.
Does that set in immediately, or is it kind of like you progress into full?
It can set in pretty immediately within hours, but there's sometimes some neuronal shock, and then it comes on over the course of several hours or so. With decorticate rigidity, you have upper extremity flexion and lower extremity extension. Okay, so there's not as many E's in that, right? We only got 2 E's versus the 4 E's in decerebrate. So decorticate is upper extremity flexion, lower extremity extension. So here's the two characteristic postures here. So this is the top one is decerebrate, okay, and the bottom one is decorticate. So just kind of like helping us understand why this occurs is we'll use this kind of model here. Remember that we have, these brainstem pathways. This is mainly relying on these brainstem pathways that tend to influence our body when we either have control from our cortex or don't have control from our cortex, okay? Remember we have some tracts that tend to bias extension in the brainstem. So we have one of the reticulospinal tracts and the lateral vestibulospinal tract. These two guys are heavily extension biased tracts. They tend to facilitate extensor muscles and anti-gravity muscles in your body, okay? Trunk, legs, okay? They function normally with minimal cortical influence. So even if the cortex is damaged, they tend to exert the same amount of influence over extensors, okay? Then you have some flexor biased tracts. And they influence they influence the nervous system a little bit differently. The medullary or lateral reticulospinal tract typically plays an inhibitory role over extensors, as long as it has normal cortical influence. So as long as the cortex, there's actually a cortical reticular tracts, little pathways from the cortex that go down to say, hey, do your job to inhibit extensors. Balance these extensor bias tracts by inhibiting some extensors. That's your normal role when you have normal cortical influence. The rubrospinal tract facilitates upper extremity flexors, but only to a certain extent as long as it has normal cortical influence. So the rubrospinal tract will facilitate upper extremity flexion, but does it at an appropriate level as long as the cortex says, hey, go ahead and do a little facilitation of our extremity flexors, but not too much, just enough to balance those extensor bias tracts. So everything's about a balance between flexion and extension, right? And some of it depends on posture. You know, if you're standing upright or sitting upright, you need to bias more extensors just to keep your posture up against gravity. If you're sitting at a table, then that's not as big a deal. So these tracts, their influence changes a little bit also depending on the posture you're in, okay? But don't worry too much of that right now. So if you have a problem above the brainstem, so if it's just a big lesion that involves enough of your cerebrum, okay? So you've lost some cortical influence, okay? So you've lost some cortical influence. We're going to talk about decorticate. Cortical, decorticate, you've lost cortical influence, okay? So what happens when you lose cortical influence, then you have, so decorticate, you have upper extremity flexion and lower extremity extension. Because what happens here is you've got the extension bias from these two tracts, they're working fine, but you lose cortical influence over this lateral reticulospinal tract, which normally inhibits extensors, so it allows more extension, especially lower body and trunk, okay? But you've also lost cortical influence over the rubrospinal tracts, which normally the rubrospinal has an appropriate amount of flexion bias, but you've lost that appropriate regulator of the cortex. So now it's too much flexion of the upper extremities. They're overactive because normally the cortex creates a little inhibition of the rubrospinal tract, so you don't have too much upper extremity flexion. It's all about that balance. So when you lose the cortex, rubrospinal tract gets overactive, and the lateral reticular or medullary reticulospinal tracts that normally inhibit extensors, you lose that now they're no longer inhibiting it as well because the cortex doesn't tell them to inhibit it. So now they lose that inhibitory. So now you're totally dominated by these extensor bias tracts. And so you get extension in the trunk and lower limbs and flexion of the upper extremity. Does that make sense? When you lose the cortical influence of those brainstem tracts. That's the overall picture, okay? And if you only lose, so if somebody has bilateral, their upper extremities and lower extremities are in this position, that means a significant portion of their cerebrum on both sides is involved. This is somebody with massive swelling in their brain, and the whole cortex is involved, okay? Somebody who just has a stroke on one side and involves a decent amount of their cerebrum on one side, they will have that decorticate posturing in a sense, but only on one side. And this is what we commonly see in a stroke patient is upper extremity flexion, lower extremity extension because because of damage to those cortical pathways that normally modulate the brainstem centers and how those influence brainstem tracts. Does that make some sense? So you tend to get this release of the rubrospinal tract to the upper extremity that causes too much upper extremity flexion and release of some of the brainstem pathways that causes too much extension that are already biased into extension because you lose that lateral cortical spinal tract mainly, and then there's some tracts that go down and talk to the brainstem to keep it under control. Now, that's decorticate posturing, upper extremity flexion, lower extremity extension. Decerebrate posturing is different. Decerebrate posturing, your red nucleus is down here, right? and it crosses over in the ventral tegmental decussation there. To go down to the upper extremities to bias upper extremity flexion, okay? If you have damage that knocks out the midbrain, and this is what happens when you have a big, big lesion of the cerebrum, or you get a lot of shearing where, like, because the cerebrum's sitting on top of your midbrain, you get this rapid deceleration injury in an auto accident or something, you can shear the midbrain, and the midbrain fibers in the rubrospinal tract get damaged. If you lose the rubrospinal tract, you lose a lot of facilitation of flexion in your upper extremities. And so everything below that, all the other brainstem pathways, the pontine reticulospinal tract, the lateral vestibulospinal tract, all do extension. And so you've lost, and you've also lost because these cortical spinal, like the lateral cortical spinal tract coming down, it's being blocked at the midbrain too. And so you have no ability to voluntarily control your limbs and so forth, and so everything goes into total extension because the rubrospinal pathways are no longer helping. They're no longer causing the flexion that they did when you just had the cortex involved. Now if you hit that midbrain and knock that midbrain out, everything goes into extension because you've lost that influence of those rubrospinal tracts. So the decerebrate posturing is often worse. That means typically your cortex and your brainstem are involved, that upper part of your brainstem. Okay? Hopefully that makes sense to you guys. And that's also why, remember, we see this common posturing with cortical lesions, whether it be a tumor, stroke, whatever. Up in the cortex, you often see this pattern on one side of the body that is similar to a decorticate posturing on one side. If somebody has decerebrate or decorticate posturing involving both limbs and both, on both sides, that's bad. That means a big part of their nervous system is saying, we're messed up, and we're vulnerable right now. Okay. Let's. Any questions on that? Let's take a break here. It's 10 o'clock, so let's just take about a 7 to 10 minute break or so and get back here. Record. So we haven't covered a lot yet today, I noticed on your handout, but we're going to pick up the pace here. So we're still on problems with motor disorders, and we're on the topic of muscle tone still. And we talked about hypertonia and hypotonia, and then some characteristic tone problems like these stereotypical things of decerebrate and decorticate posturing, okay? But now we're just going to talk about how we assess muscle tone, okay? No matter what their problem, whether it's low or high. So typically it's through passive range of motion. You typically have the person relax, tell them not to help you, and you move the limb. It can be in any direction, Typically if it's a leg, you pick the leg up and you go flex, extend. Sometimes that's all I do. Sometimes I'll pick it up, I'll do a little flex, extend, I'll rotate it a little bit, make sure you get the ankle a little bit, I'll bend the knee, usually the hip and knee together. Sometimes I'll bring it down to a little ab and adduction just to make sure I get all the different motions to see if I'm feeling resistance or lack of resistance in any direction. The upper extremity, I guess, it's kind of flexion, extension, little ab and adduction, maybe elbow flexion, extension, wrist flexion, extension, hand flexion, extension, okay? And we'll go through that today real quick in lab. Then you're going to grade it or rate it, and it's still somewhat a subjective type rating scales, okay? There's not a great way for us in the clinic to assess tone in a, specific sensitive manner where you get this nice readout. It's not like handheld dynamometry where you're getting kilograms or foot-pounds. There's no great way in the clinic to say that the person has a 4.7 resistance level into passive stretch or something like that. We do assign some numerical values, but they're kind of subjective in nature. So the most common one we use is called the modified Ashworth scale, and we'll show you if those levels or categories. There's another one called the Tardot scale that also is similar to the modified Ashworth scale. It's a rating scale, but you'd actually do 3 different velocities, V1, V2, and V3, these 3 different velocities, so you're looking at the velocity dependency as well. I typically don't do the Tardot and I don't do 3 velocities. I typically do the modified Ashworth, which is just during slow movement. Then I'll superimpose a few quick motions and just say if it goes up from there, if they've got some increase but that's separate from the modified Ashworth. The modified Ashworth is typically during just slow movement, okay? Come on. Okay. So here's the modified Ashworth scale. So they added the 1+ on this. That's why it's modified. It used to be just, the 4-point scale, or 0 to 4, and then they've added the 1+ in here. So 0, no increase in muscle tone. That's not 0 muscle tone, okay? So 0 would be normal, okay? So 0 would be normal. It's not flaccid if it's a 0. That's just, there's no increase in muscle tone. If it's flaccid, I just have to say they're flaccid or hypotonic. The modified Ashworth scale is purely for increases in tone or increases in spasticity, okay? A 1 is a slight increase in muscle tone. So you lift the limb up and you start to move it, and you typically notice a little catch and release, or by minimal resistance at the end of range of motion when the affected part is moved into flexion or extension. So maybe I go ahead and I pick up their leg, and as soon as I start to move it, I notice a little catch, and then it kind of releases, but it feels pretty normal after that. Or vice versa, I lift it up, and I notice they feel pretty normal, but then I get to the end, and it seems to get a little stiffer just at the end, okay, at the very end of range. But for the most part, it feels pretty good. It's almost hard for me to tell if it's normal or not. I might feel this little catch or resistance at the beginning or very end of the range of motion, but it's mild in nature, okay? But the affected parts still move easily, Everything moves easily when I do this. I'm not grunting and straining to do this. A 1+ is a slight increase in muscle tone manifested by a catch initially. So you get up and you notice it feels like a little harder to get it started. And then minimal resistance throughout the remainder, but less than half of the range of motion. So you feel like the less than half of the range of motion is you're feeling that resistance or restricted. So, what if you're at 49% of the range of motion versus 50%, or 40 versus 50, or 50 versus 60? It gets hard sometimes to know, is that half the range or more than the full range, okay? What I would say, though, is a 1+ is you have resistance, slight resistance through a fairly decent part of the range, whether that's 50, 49, whatever, but you'll notice that they have some resistance, this minimal resistance. When you get to a 2, it's more marked increase in muscle tone through most of the range of motion, so more than half, or almost the entire, it feels the same the entire way, and you feel resistance the entire way. Little more than a 1+, but more resistance through more of the motion, okay? But the part is still fairly easily moved. You're still not having to try to work at it to get that limb to move. It's still able to move it through that fairly smoothly. 3 is where now you're pick that limb up, and just to even get that knee to start to unlock so you can actually do it, sometimes you almost have to rotate the limb sometimes and do some funky maneuvers, and then all right, it's going, but as you move it, you're working at it. It's hard to move that limb through that motion, relatively hard. You're having to work at it. That's a 3. 4 is decerebrate or decorticate posturing, where you can't even break that. I've literally had people that, like I say, the people that are just their occiput and their heels are on the table, on the ground. I can't even physically unlock their knee. I can't even unlock it to get it to. The only way I can typically unlock it is if I'm allowed to, if they don't have ICP monitors and vents and all that, get them on their side. If you put somebody on their side, that tends to break up the postural tone, because there's some, you guys have learned about the tonic labyrinthine reflex at all? Did you learn about that in peds yet or not? There's a reflex associated with your vestibular system that when you're laying on your back, it tends to promote more extension because of the connections to the vestibulospinal tracts, okay, and so if you get somebody on their side, that changes the position of the vestibular system so that it tends to down-regulate those extensors a little bit, and sometimes then I can break that tone up if I get them on their side, or if I flex their trunk a little bit. If I get them on their side and flex their trunk, then I can get their other limbs to tend to want to flex a little bit. That's a 4, rigid flexion or extension. So that's different than reflexes, right? So there's reflexes which all have the plus on it, 0 reflexes is absent reflexes, and that's our quick stretch reflexes. This is totally something different. This is through passive motion, a different grading scale, even though it's very similar in the number, range, because the reflexes are also a 0 to 4 scale, right? Our muscle stretch reflexes. But they all have a plus on the end. However, in the modified Ashworth, we just have that 1 with the plus on it. That's that additional, gradation in the scale that was added on later. So that's muscle tone. The other thing that can be affected or influenced when you have motor problems is reflexes, okay? And we have two different types of reflexes: cutaneous reflexes that are done by stroking the surface of the skin, or deep tendon reflexes. We already talked about the Babinski reflex. You stroke up the bottom of the foot. There's a thing called the flexor withdrawal reflex, like tickling the bottom of their foot and your foot lifts up. That's a flexor withdrawal reflex. We still have that reflex. It's normal to have that reflex, but some people with a damaged nervous system, normally if you touch somebody's foot, they know if it's non-noxious or you're just trying to tickle them, they're not going to do this extreme where their whole leg goes up as far as it'll go. But if somebody's there's a few of you might, but if you're somebody who's got a brain damage or brainstem damage, you go and touch the bottom of their foot or poke it with something, and it just goes boom, and it does the full flexion synergy to the maximum. That's more of an abnormal withdrawal reflex. Or you try to put them up on their feet, and when their balls of their feet hit the ground, they draw up into flexion. That's an abnormal withdrawal reflex. Any touching the bottom of the feet, they draw up like this. They can't support themselves. The abdominal reflex we talked about, where you scrape up the bottom of scrape up the side of your umbilicus, and you're just looking for contraction of those muscles underneath it. There's a thing called the glabellar reflex. You actually tap on the person's head, you walk up to them, and you have their eyes open, and you just start tapping on their head. And so normally what happens is you might blink the first time or two, but after that, you don't blink. Like tapping on my forehead or somebody else tapping your forehead doesn't cause you to blink. People with a glabellar reflex will blink every time, and it never diminishes the blink reflex, and that doesn't habituate. It's normal to habituate to somebody tapping on your head so you don't perceive it as a threat. But somebody with Parkinson's disease and some other disorders will have a persistent glabellar reflex. You just use your finger, not your reflex hammer or anything like that. Deep tendon reflexes we already talked about. We know what those are. Those are looking at that monosynaptic stretch reflex at the spinal cord level. So here's the grading scale for stretch reflexes. So it's a 0 to actually 5+ they have here. But most don't go to 5+. This scale shows a 5+ on it, right? Typically it's a 4+ with this, but there obviously are occasional references that'll show a 5+. I usually stop at a 4+ here. So 0 is absent, no palpable muscle contraction, even with reinforcement. So that's doing one of those Jendrassic maneuvers, right? So you can't elicit any palpable contraction, even if they do the whole, for the lower body, you have them do this where they clasp their hands, and then you time it where they pull and create a co-contraction, which raises the tonal set of the entire nervous system a little bit when you do that isometric contraction. And then you see if their legs, or vice versa, you have them squeeze something between their legs, like a ball or a towel or something, while you're doing their upper extremity reflexes. So they have 0 even with reinforcement. Hyporeflexia, which can be normal for certain people. Slight or sluggish, with little or no joint movement. Reinforcement may be required to elicit that reflex. You may need to do one of those Jendrassic maneuvers. 2+ is normal. Slight muscle contraction with slight joint movement. Hyper. 3+, clearly visible brisk muscle contraction with moderate joint movement. 4+, strong muscle contraction with this says 1 to 3 beat clonus. Some people will just say with clonus, where that actually keeps beating back at you a few times. Might self-perpetuating a little bit. You tap on that tendon, and they go boom, and then they go. As soon as you tap on the tendon, they go boing, and then they relax, and it does it again a couple times, and then it diminishes down because each time the leg falls, it creates another quick stretch. And so that's a 4+. Or you stretch their ankle, and you test that, and the ankle just keeps beating back at you. We'll show you how to test for clonus here in a few. Then 5+, they're saying here, is where the clonus doesn't go away. You stretch it, and the clonus, as long as you maintain that stretch, it just keeps beating indefinitely. And it may even spread to the other side, to the contralateral side. So they start, one leg starts going, or they're, you'll see this with somebody with spinal cord injury. They're rolling down the road in their wheelchair or whatever, and their foot is on the wheelchair pedal, and they hit a bump, and they get a quick stretch of their gastroc, and maybe one side just starts going, but then that causes the other side to start going, and you get the spread of clonus. And some people will actually use it functionally. Some people with spinal cord injury have really high 4 or 5 plus spasticity. To do a sit-to-stand transfer, they'll actually self-stretch. They'll be sitting on the edge of the bed or like this, and they'll create an actual quick stretch of their gastrocs and get their clonus going, and use their clonus to actually create extension in their limbs so they can actually do a transfer, a functional transfer, and things like that. So spasticity is not always bad. And sometimes you take that away from somebody, like, oh, I want to reduce your spasticity, so they do a Botox injection, and all of a sudden they realize, oh, I was using that for something else. That's helped me stand or do this. Now I want it back. Fortunately, with Botox, you wait a few months and it goes away. Movement efficiency and speed is another thing that we have issues with motor problems. Primarily, we see this through observation, okay? Also known as kind of coordination, okay? The big, topical area of coordination. We can do this by just watching the person walk or move during functional activity. So oftentimes I'll describe how coordinated they look during gait or during transfers and those kind of things. How effectively are they moving? I can do more formal testing, finger to nose testing for coordination to see how smooth, quick they can move that limb. Rapid alternating movement. We'll do that in the lab too, this flipping their hands over side to side, this rapid alternating movement. And heel to shin testing. Sometimes we'll have people drag their heel up their shin lightly, smoothly, in a controlled way to see their coordination of their lower limb. It's just a crude, kind of quick, simple way to measure coordination. If they can't keep that heel on their shin and move it nice and if it's flopping side to side, or they can't move it in that position, then that can be a sign of lack of coordination. Postural control is another big area that you see problems with, any kind of problem in the motor system. Typically it's through observation is our most common way we do that. However, there are some formal balance testing devices out there, these force plates and things like that give us hard numbers. But typically something as simple as a Romberg sign. You guys know what a Romberg sign is? So testing postural control, so you just have the person stand there with their eyes open, look at their postural sway. How well can they stand there for 30 to 60 seconds? And then have them close their eyes. And then just see what happens when you lose the visual orientation. How does their postural sway? It's normal to have a little more postural sway when your eyes are closed, but not to just start kind of, whoa, and having all kinds of problems, okay? That's a Romberg test or Romberg sign. There's a sharpened Romberg. If that's too easy for some people, you put them with their one foot in front of the other in a tandem stance. That's the sharpened or tandem Romberg test. And you have to do the same thing, eyes open and eyes closed with your feet in front. You do that for your higher level patients. Then there's, Tonetti, Berg, mini best test, all kinds of balance scales that take you through different categories and you test them and score them on. Those are all forms of postural control or balance you're measuring. The Balance Master is just a fancy electronic device with force plates built into it that tells you about their postural sway under different conditions. Another simple way to look at postural control is gait. Just watching somebody walk, I'm assessing postural control, movement fluidity, all those kind of things. But you can then have them do some more challenging things, like make them walk heel to toe, make them walk on their toes, make them walk on their heels, and you get to see some other things that happen in gait when you do just some of those simple challenges with them. I don't think your book organizes the approach to looking at motor disorders this way. When I went back through, but this is a really good way to look at classifying motor disorders, okay? You can fit any motor disorder typically into one of these 4 very broad categories, okay? Sometimes your patients will fit into multiple categories. If you've got a patient with a stroke who also has peripheral neuropathy, they could be in two separate categories. Does that make sense? Or a person with a stroke who also has Parkinson's disease. I see that very commonly. A person who's got Parkinson's disease, as they get older, they're vulnerable to having a stroke too. So that can put you in two different categories. So understand that your patients will often fit under more than one category. But these are the four areas: a lower motor neuron disorder, and you might even put in parentheses there peripheral, peripheral disorder, or peripheral motor problem, okay? Then an upper motor neuron problem, sometimes known as a pyramidal disorder in some textbooks. If you hear the term pyramidal, they've got a pyramidal tract problem or pyramidal motor disorder. That means an upper motor neuron problem. A basal ganglia disorder. Sometimes you'll hear that referred to as an extrapyramidal disorder. It's outside of the normal motor pathways. It's called a basal ganglia disorder. Cerebellar disorder is the other big category. It's also a type of extrapyramidal motor disorder. Those terms are outdated, pyramidal and extrapyramidal, but you may see them in some of your readings, and I just don't want you to get confused in other textbooks or research articles you read about. We included 7 subjects with pyramidal motor disorders. You're like, what the heck's a pyramidal? That just means it's probably a stroke or a brain injury or something involving the upper motor neurons. Or we included 7 subjects that are extrapyramidal disorders. It means they have basal ganglia or cerebellar problems, but these are the 4. So we're going to go through each of those 4 and then just look at how each influences those things we just talked about: movement efficiency, speed, tone, bulk, reflexes, okay? And make sure you feel comfortable with that. So here they are. So here's the clinical manifestations typically. This is all typical. There's always exceptions, and there's always some variability in how it's presented, but this is the most typical that you're going to see. So under the category of muscle strength and bulk, you're going to see with a lower motor neuron problem, there's going to be some decrease in muscle strength and bulk, okay? Including up to flaccid paralysis. That's 0 strength and profound bulk and atrophy problems, okay? But it can be anything in between, If you have just a mild compression of a spinal nerve root, you're going to have some subtle weakness and some subtle bulk problems. Not too bad, but it can be as bad as flaccid paralysis. If you have abnormal muscle contractions or involuntary muscle contractions, you may have fibrillations. Fibrillations are those little single motor fibers just spontaneously popping off because you have deinnervation going on. There's lack of nerve supply going. It's a lower motor neuron problem. This is a lower motor neuron is the anterior horn cell body or its axon anywhere in the periphery. That's a lower motor neuron problem. Muscle tone will likely be decreased. If it's severe enough, tone will be decreased because you've reduced that there's no more input going to the muscle, or it's reduced. So the muscle's not getting normal input, so its tone is down. Reflexes are often absent. If the weakness is in a muscle that has a testable reflex, then you might notice it's down-regulated because you can't send the signal back or to the muscle to make it be reflexive. Does that make sense? A movement efficiency and speed. If you have enough weakness, you're going to have problems moving your limb properly. If I want to do finger to nose testing and I've got a paralyzed bicep, it's going to be pretty hard for me to do. I'm going to notice problems with coordination and problems with movement efficiency and speed. And that can be where they have absent movement to just more subtle impairments because of weakness. Postural control may or may not be that impacted. However, it may be impaired if there's enough strength deficits, especially in the trunk and lower limbs, because in order to maintain postural control, you have to have a certain amount of baseline strength to maintain your posture against gravity. So if you have a lot of weakness in your ankles and feet or knees or trunk and back, it can be hard to maintain that postural control, or you look a little wobbly because your muscles are struggling with that. Oftentimes, if somebody has a lot of weakness in the lower legs, it's because they have peripheral neuropathy, so sensation will often also be affected. So they're also not getting sensory input from the floor, so that can make their posture look bad, and they'll have that positive Romberg sign when you close your eyes, because now I got to rely on what are my feet feeling. If I don't feel anything, plus my ankles are weak, I'm going to be all over the place if that's a lower motor neuron problem. Because a lower motor neuron problem is usually a peripheral problem, and remember those peripheral nerves are mixed, so often you have sensory and motor together that are at an issue there. Lower motor neuron, there we go. Now, examples of lower motor neuron disorders. These are common lower motor neuron disorders. Guillain-Barré syndrome. Remember Guillain-Barré? That's that damage to the myelin sheath, especially to the anterior roots that go to make that spinal nerve. So that's why Guillain-Barré is specifically more motor than it is sensory, okay? Because you actually damage the myelin on the anterior root more so than the posterior root. And so that's why they have pure motor weakness. It's very stereotypical pure motor weakness. Polio, which we're not going to be seeing these patients. I mean, we're seeing them now because we're seeing some of the older adults that have this post-polio syndrome. They had it as a young child, and now they're in their 70s and 80s, and they having some more symptoms related to that as they've gotten older. Or in some foreign countries, you still have some polio outbreaks. But that is damaging. That's pure motor, and it's damages just the anterior horn cell, kills off the anterior horn cell in the spinal cord, and therefore the axon also dies off, and you lose muscle innervation, okay, motor innervation. But lower motor neuron doesn't affect any of the pathways in the spinal cord, just the anterior horn cell sitting in that ventral horn, and then kills it off. A radiculopathy, that's compression of a spinal nerve. After the dorsal and ventral roots come together, that spinal nerve, as it exits out the vertebral foramina and goes down before it divides into your peripheral nerves, that's a radiculopathy. That's going to cause a myotomal loss, in the myotome, C5, C6, and often dermatonal loss of sensation because you're affecting that mixed nerve now. They're sensory and motor together in that spinal nerve. So often you'll have both motor problems that we're talking about today, but also some sensory issues in a myotomal or dermatonal type pattern. Then we have peripheral neuropathy. Peripheral neuropathy would be that more distal is worse to proximal, okay, distal to proximal. That was good. I remembered Guillain-Barré syndrome, something I mentioned, and I happened to say it in passing in a lecture a long time back about that's how it presents itself, distal to proximal and proximal to distal. I told you, I mixed it up and told you the wrong way, scenario, so let me just reinforce. So Guillain-Barré, so if you damage the ventral roots, motor signals are having a hard time getting out, right, and getting to their muscles. Which muscles would likely have the lesser chance of getting that signal? Which muscles, distal or proximal initially? Distal. You got to send that signal farther to go distal, right? And so any kind of damage, even initially, is going to make it harder to get the signal to go the farthest distance. So with Guillain-Barré, it starts distally, the weakness, and works proximally, okay? Then recovery is kind of the opposite, right? Because as you recover and build that myelin, the signals are going to first get to the more proximal muscles before they kind of peter out. And so the recovery is proximal to distal. The onset is distal to proximal. Recovery is proximal to distal. And so oftentimes with a Guillain-Barré patient, when they're starting to recover, I'm doing a lot of core work and proximal muscle work while we're waiting for the distal muscles to come back, because I can't even exercise. If their anterior, tibs and their gastroc aren't even firing, how am I going to exercise that? So a lot of times we're spending time working, but we can start working on core stuff when those muscles start coming back. So anyway, just want to make sure it's clear on that. But peripheral neuropathy is typically associated with diabetes or idiopathic peripheral neuropathy, where again, distal to proximal, the nerve is dying back. It's not the signal getting there, it's just the nerve is dying back because of they usually don't have good vascularity to their distal limb, and those smaller nerves, distal nerves, are more vulnerable to damage, and they get that stocking and glove pattern eventually. This is what a neuropathic gait looks like. It's pretty quick, so you have to watch it quick. Replete. It's worse on his left, but he's got it on both sides. We call this a steppage gait or a foot slap gait. So he's walking, and his lower limbs are weaker than his proximal. His hips and so forth are pretty good. So when he picks his foot up, his dorsiflexors aren't holding his ankle up or his foot up. So in order to compensate so he doesn't drag his foot, he's got to increase his hip and knee flexion to lift that leg to make sure it doesn't drag. So as he's stepping, you see his foot's dropping down like this, and then when he goes to place it down, his actual forefoot hits first, then his heel comes down. And often it sounds, they have this kind of noisy walk like this. And they have to step higher. That's why they call it a steppage gait, because they're just trying to compensate for those lower legs not doing their job and not keeping the toes up when they walk. And so this is what they call a steppage gait. I've got a neighbor who walks every day, and I'm watching him over the last, I see him every day for the last 5 years, and I'm watching his neuropathy get worse and worse. I think he's just got idiopathic neuropathy. But I've kind of want to say, hey, you know, but he's kind of the neighbor that nobody likes in the neighborhood, and he's always just ornery. You know, he'll take it the wrong way if I say, I notice your neuropathy. He'd be great in carbon fiber AFOs, which, you know, some real lightweight carbon fibers like this guy would be, and make him walk a lot better. He's the neighbor guy in the cul-de-sac that, you know, buys in a neighborhood. He has no children, and that gets mad at everybody else that has children in the neighborhood. And like, you know, if your paper airplane ends up in his yard, he gets mad at you. He actually sued my neighbor because he found a dent in his garage, and he just assumed that their kids, because they have one of these little like electric cars they drive around. He goes, I know your kids dented my garage. And he said, no, I don't. Our kids never were up in your driveway. He says, well, who else could it be? How else could my garage get dented? So he sued him for $1,000. I'm like, okay. So maybe he doesn't deserve to have new AFOs or anything. So any questions on lower motor neuron problems? Okay, upper motor neuron. This is damage to the descending pathway anywhere along the line in the cerebrum, brainstem, spinal cord, okay? These are some of the common symptoms you'll see when you have damage to that pathway, those tracks we're talking about, the tracks. We'll see decreased, so muscle strength and bulk, we'll see decreased, but typically not as severe as a lower motor neuron. We have paresis, not paralysis. So they're often weak because of this. Like if you have a stroke in the brain, that makes you weak because your lateral cortical spinal tract, medial cortical spinal tract are somewhat affected, obviously, can be affected, and you have a hard time sending the right signals down there. But you still have your brainstem tracts that are working, you know, that are postural muscles and things like that. And they still typically can move their limb with the brainstem tracts, but it's this pattern, but it's enough to keep some stimulation of the muscle going and keep some bulk. But over time, they get disuse atrophy and some weakness, right? They're typically weak. It's hard to sometimes manual muscle test them because you can't isolate the movement. You can't just say, just contract your bicep here. You say, well, I'm going to test your bicep, and they go like this, you know, when you're trying to test their bicep. They can't just do this. It's just this pattern movement. Same thing with the leg. Muscle contractions, or involuntary muscle contractions, we should say here, is they have fibrillations, not as bad typically as lower motor neuron, but fibrillations. They will sometimes have spasms and cramping also associated with their increase in tone and spasticity. So going along now to muscle tone, they typically have increased resting tone. So when you lift their limb up, arm, leg, it feels a little bit resistance, extra resistance. They also typically have some spasticity. The faster you move it, the more it resists you. Or you tap on their tendon, they're hyperactive. That's as long as you're after that first few days or weeks of neuronal shock, remember? So this is what they're like chronically over time, okay? Not that remember there's that immediate period of neuronal shock, even with upper motor neuron problems, that makes it look like lower motor neuron, but this is after that's resolved. Spinal cord injury is a little different. Spinal cord injury, because you've damaged the spinal cord, now you've also, not only have you limited the cortical spinal tracts, but the brainstem medial activating system tracts have also been impacted. So what happens is you no longer have this influence of those that maintain some of the resting tone. So at rest, some of the spinal cord injury looks like they have low tone, okay? Because they don't have that influence from those higher centers at all, including those brainstem tracts. But they still have that reflex at the spinal cord level that when you tap on a tendon or you try to elicit clonus, it's really high. The velocity-dependent spasticity is really heightened with spinal cord injury, okay? But the resting tone that's modulated often by those brainstem tracts is no longer as an influence, so the resting tone isn't as high. They almost feel flaccid, but they're not flaccid, but they almost feel flaccid at rest. But as soon as you move them quickly, boom, they have these reflexes and these tone, and not tone, but spasticity and clonus you can kick in of any kind of rapid stretch, because the monosynaptic reflex is very overactive, because normally those pathways help modulate that. Somebody with a stroke who you've got still the brainstem pathways that are telling the limb to be kind of stiff or the limb to be stiff, that maintains some tone and it feels stiff. But when you tap on a tendon, you get a hyperactive reflex, but it doesn't look as bad as a spinal cord because you've got co-contraction. Like when I tap on a tendon of somebody with a brainstem or a stroke, oftentimes their tricep or their other muscle will resist and and dampen that down a little bit, so it doesn't look quite as hyperactive. With spinal cord injury, you don't have any of that going on. There's none of this hypertonicity that modulates or masks the hyperactive reflex a little bit. Does that make sense? Okay. So some subtle differences in how those manifest between brainstem and cerebral lesions versus a pure spinal cord lesion. So with reflexes, they're typically increased. Any kind of damage, whether it's spinal cord, brainstem, they have increased reflexes. And they also may have some abnormal cutaneous and primitive reflexes. This is where you might have a Babinski sign, okay, or a Hoffman's reflex in the upper extremity, which is the kind of equivalent of a Babinski sign in the upper extremity. We'll show you how to do a Hoffman reflex in lab. Movement efficiency and speed, you have often impaired abnormal timing of muscle activation and loss of fractionation of movement. So they have difficulty, if you've got a stroke or a brain injury, you can't do those nice fractionated movements. You get this pattern movement, but it's hard for them to do nice isolated, just move your wrist, just move your elbow, just move your fingers. They can't do that because you lose that lateral corticospinal tract is the one you're damaging. They're more dominated by those brainstem tracts that are more postural, bilateral tracts that kind of cause just gross move. They're for more gross movement. And then postural control can also be impaired depending on the lesion. If I've got somebody who's got a weak spastic leg and they're standing like this, their balance reactions are not going to be very, very good on this side. You know, they're going to have trouble with maintaining postural control. They might also have some weakness in the trunk. Usually not as bad because usually have bilateral connections in the trunk, but they might have some little bit of trunk weakness and postural control problems. Some of the abnormal cutaneous reflexes we mentioned, Babinski sign, flexor withdrawal, and abnormal overactive flexor withdrawal. And then the Hoffman's, which is this, we flick the fingernail, we'll show you how to do that, and then you see a reflex of what you do is you take usually their middle fingernail and you put it over yours and you flick it like this. You're just going like this, and what happens is normally nothing happens. You just flick that, and my hand doesn't do anything, but with somebody with a Hoffman reflex, you flick it, and the index finger and the thumb kind of do this little winking, and they come together and do this little, and it just keeps, every time you do it, that the thumb and the forefinger, the index finger come together. That's a sign of an upper motor neuron problem in the upper extremity, kind of like just the Babinski sign is a sign of an upper motor neuron problem. It doesn't tell you exactly where in the nervous system, it just says it's somewhere in the brain, brainstem, or spinal cord that you've got some kind of problem that's influencing your upper body. Abnormal timing and muscle activation, you know, they might have trouble with initiation of movement, the rate of force development, how quickly they can make a contraction. You know, if you've got an upper motor neuron problem, it can be hard to develop contraction quickly for power movements. And then once they do contract it, it stays on too long sometimes. They have a hard time turning it on quickly and also turning it off quickly. Normal movement, you should be able to turn it on, turn it off, so you can get quick reversals of motion and direction. Or somebody with a stroke, you say, all right, lift your arm up. There's a delay, and they try to turn it on, and it's kind of slow. And then you say, all right, you can let it down now, relax. Okay. And they have to kind of think about it to let it relax too. Okay, so there's overlap, and there's activation sometimes of both agonist and antagonist at the same time. So when they overcontract muscles sometimes on both sides of the joint, they're kind of defaulting to stability, you know. Let's turn the muscles on, especially those brainstem tracts, because they're both bilateral, and they also tend to influence muscles that tend to create postural stability, that they overdo that. So when you want to move your hand quickly or your leg quickly in an isolated, fractionated way, you can't, because everything's kind of contracting around it to provide more of this postural stability and control. This is all upper motor neuron, okay? Then your book gets into all these crazy terms that are associated typically with an upper motor neuron problem. So I'm not going to define and go through all the ones, but the ones that I think are key and more commonly used, okay? So if you hear the term co-contraction, like you're out in the clinic and your patient and your therapist is saying, this patient with a stroke, look at all the co-contraction he's getting at his shoulder or whatever. What they mean is there's a temporal overlap of agonist and antagonist that there shouldn't be, you know. I mean, there are times, there's certain activities you want co-contraction, you know. If I'm doing a push-up, I want co-contraction of my deltoid and my anterior deltoid, posterior deltoid, my lats. You know, I want co-contraction to provide stability or something like that. But then there's times when I have somebody who's just trying to lift their arm doing an open chain activity. Most open chain activities, you don't need a lot of co-contraction versus a closed chain. But somebody with, you know, they get too much co-contraction here. They're getting bicep, wrist flexors and all that. I don't want all that. Or I'm getting bicep and tricep contracting at the same time, and there's some, you know, overlap between the two that you don't want. It makes it hard for them to quickly move their limb, flex, extend, straighten, you know, bend, because they can't turn one muscle on isolated and turn the other muscle off and do that quickly, okay? Like I say, it is normal under certain circumstances. You do want co-contraction, but you don't want excessive co-contraction. Contracture. Most of your patients who have upper motor neuron problems will end up with contracture. It's just a side effect of having too much tone in your muscles and sitting too much and laying too much, basically. So most of your patients, after a big stroke or after a neurologic problem, they're not going to be moving as much. They're going to be laying in bed or sitting, and they're going to get contractures or tightness in muscles that are commonly prone to tone. So the gastroc is the big one, okay? That's one of the extensor muscles in your limb that's mediated by those medial corticospinal tracts. So most of your patients, despite your best efforts of positioning, providing a brace for the foot, will end up with some form of plantar flesh contracture. Could be subtle, could be severe, and it's almost impossible to stop it. The only way you can stop it is the faster you get them up walking, and doing lots of weight bearing and walking is probably the only way, because just you trying to stretch it a couple times a day, it's hard to stretch a gastroc. It's just too big of a muscle, too short of a lever arm, and you're fighting an uphill battle because of all the tone that they're getting, and they're laying in bed, you know, 10, 12 hours a day. They're going to end up with some shortening, okay? Contracture can happen whether you have a neurologic problem or not, but it's enhanced with a neurologic problem, and especially when you have increased tone. You get the adaptive shortening of the muscle. Eventually, you actually lose sarcomeres. You actually lose some of those muscle cells and sarcomeres over time, because when they're so shortened, you don't need them lengthened. You also get some increased cross-linking between the fibers, okay, between muscle fibers. Contracture is one component or one contributor to this bigger term, overarching term called myoplastic hyperstiffness. Myoplastic hyperstiffness includes both the neurogenic component and the physiologic contracture, you know, component. So that's what we'll get to next, is myoplastic hyperstiffness. I added a little bit to this slide. Excessive resistance to muscle stretch due to structural changes within the muscle. So there's actual structural changes that are brought on by changes in neuromuscular activity, okay? I mean, I can take somebody who has a normal nervous system and I can put their leg in a cast with their foot like this, and you may have experienced and develop a contracture in somebody. This is myoplastic hyperstiffness comes because the person has a damaged nervous system that leads eventually to this myoplastic hyperstiffness, okay? So you get contracture, you actually get loss of sarcomeres, okay? And adhesing down of fibers, but you also get increased in this weak actin-myosin bonding. So the actin and myosin filaments, they're overlapping too much, and they're overlapping all the time, and they kind of get sticky to each other, you know. So it's just hard for them to release. So it's like if they're Velcro, they get like pushed on a little bit. You don't push on them, and you're not smashing them together too much, but they're getting smashed together a little bit. So when you try to move them, it's like trying to rip apart some lightly tacked together Velcro. Okay. You also tend to get some select atrophy of type 2 muscle fibers. Okay. And very common in stroke or brain injury. Anytime you have upper motor neuron problems that are pretty significant in nature, you're going to very commonly get this myoplastic hyperstiffness. Muscle overactivity is muscle contraction that is excessive for the task. This is not an increase in tone, like resting tone. Tone is at rest. This is where a patient actually uses too much effort for the task. They can't modulate effort. They can't match their muscle effort with the need, okay? And they end up just typically overestimating to make sure that they don't fail, but they end up expending way too much energy on things in order to lift something or do something simple. They will actually have excessive neural input to the muscles that may be due to lack of skill in performing the task, anxiety or pain, or neurologic damage. We've already talked about muscle tone. That's the amount of tension in a resting muscle. You examine it passively, not velocity dependent. It's hypertonia, okay? Upper motor neurons tend to have spastic hypertonia, so resting tone is a little bit higher, and when you move it, it is somewhat velocity dependent when you move it, okay? Versus a basal ganglia disorder tends to be what we call rigid hypertonia, where it's rigid in both directions and it's not velocity dependent. No matter how fast or slow I move my patient with Parkinson's leg, it feels the same and it feels stiff in both directions. It doesn't get worse the faster I go, it doesn't get better the slower I go, it just feels stiff. Paresis, we've already talked about that. We've talked about spasticity as the velocity dependent resistance to passive stretch. Clonus is when you're doing reflex testing or testing velocity dependent, if you elicit a quick stretch and it keeps bouncing back at you as long as you maintain that stretch, that's clonus. Okay, it's just a repeated stretch reflex that keeps being re-elicited. If you're maintaining that stretch, each time it contracts, it relaxes, and you induce the stretch again because you're trying to maintain that stretch, it's self-perpetuating. That's clonus. Most of the time, your patient, it'll dampen after a certain number of beats. So we call that 1 beat clonus, 3 beat clonus, 4 beat clonus, or sustained, if it just keeps staying and never goes away. Examples of upper motor neuron disorders. So spinal cord injury is an example of an upper motor neuron disorder. It just damages the pathways in the spinal cord. Stroke, that's going to be more in the cerebrum typically, but you can have strokes in brainstem and spinal cord as well. Multiple sclerosis, that's damage to the oligodendrocytes, the myelin surrounding the tracts, the axons in the central nervous system that are associated with your lateral cortical spinal tract, your vestibulospinal, reticulospinal tracts. Any of those tracts can be damaged. That's upper motor neuron. Spastic cerebral palsy, traumatic brain injury, all these are examples of upper motor neurons problems. So let's do this. Any questions on, what did I didn't cover, I don't know. I've got so many different variations on these presentations now. I didn't talk about the basal ganglia disorders or the cerebellar disorders, did I? Because that's what we're going to talk about next session. So what handout is on the, what was up on the website on Isidore? Do you guys know what did I have up there for Isidore? Does it? Well, but where did I end? I'm trying to remember. Did I go through?
I have the next PowerPoint too, if you want to look at that.
What's that? This is for next week. But for this week, It stopped where I stopped. Okay, I thought I looked at another version that went on, but so we did upper and lower motor neuron disorders, but then also realized there's basal ganglia and cerebellar disorders, other two big categories. So on next week we'll talk about basal ganglia and cerebellar disorders that are typically part of the control circuits that help modulate overall motor output. But so we'll focus on that. Let's work on the case. So I want you guys to go and spend the next 10 minutes or so, partner up with somebody, look at your answers, see if you got any decent guesses. And it's okay to have guesses at this point. This is our first time we're going to kind of go through and try to do some problem solving with a case and try to reason where the lesion is based on the symptoms and those kind of things. I'm going to introduce you to this little tool that has been a work in development over the years for you guys. And I keep adding a little bit to it that helps it's a checklist that helps you isolate where the lesion might be and the symptoms they're having that are associated with different motor disorders and different regions of the nervous system that are involved. So as you go through, as you're going through this case, you might be able to check off some of these boxes if you're seeing this person's symptoms and start to narrow it down that says, ooh, it looks like an acute onset. Looks like he's got a lot of symptoms in whatever region of the nervous system, and he's also got some upper motor neuron or lower motor neuron signs, so I'm thinking it's probably going to be more isolated to this region, and this is the problem. And I'll walk you through how to go through that when we go through this case. Here you go. Little check sheet. Actually, give me one copy of that. I think I printed off an extra copy so I can have one.